Just read through that. A line is made up, the lamps is digested. An interventionist by the calcium he has broken. Why we say that is because what starts off as the microtombs of the dying and the dead smooth muscle cells and macrophages coalesces into really unbelievable rocky mountains. And you can face the challenges only inside the arteries. And many a time, the way it will feels like you're playing golf in a rocky terrain, sometimes like driving a limousine in a tortuous rivulet. You have seen this, and then once you go through the challenges, then you understand the challenges we face. And here comes in my opinion, one of the greatest revolutionary innovations in cardiology, that is intravascular lithotripsy balloon. We know the three traps of calcific lesion plasty, the device crossability, the lesion crackability, and the bed carpetability. And most important is to make sure that you are not landing up with the illusion of crackability. This is always a point. Many a time it appears like you are cracking the lesion with the balloon, NC balloon. Unless you do a cine, you will miss that it is not cracked in the real part. And unsafe crackability. This is what everyone should be aware of. If we don't have all the gadgets or expertise, unsafe crackability, don't do with the NC balloon. If the waste is there, it melancetes and causes a bad dissection distally. In an uncracked lesion, it is a disaster. At the same time, the dog boning can cause dissection of the distal or proximal healthy zone if it is a short focal lesion, and then again a disaster. So make sure you're not landing up with that. We have superficial and deep calciums, and we have all the technologies we have discussed, and we are focusing now on D therapy, which is the most calcium-specific therapy. All others are not specific to the calcium. Atherectomies may to some extent are, but this is highly calcium specific. It doesn't abrade the tissues, it doesn't do any sanding or cuttings, but it causes calcium breaks within the location where it is without any extrusion of material. So no slow flows, no reflows are not there. You can use guide wires in the side lumens. There's no problem with additional wires, and it cracks both superficial and deep. The only thing is you have to be able to send it to the lesion. That is the only issue. So there are a lot of advantages there. We'll go through that. So you know that imaging is mandatory, and you know which lesions need a calcium modification. A circumferential calcium modification can be assessed even by a simple balloon boost. If you don't have any imaging modality with you, put an NC balloon before opening up the balloon. Try to see a stent boost, the so-called stent boost with a plain balloon NC. You can see in two orthogonal views, and you know whether the calcium is all around, deep and long, and you know you have to modify the lesion. It's a simple man's imaging technique. Why I say it is revolutionized? Because I'll show you some examples. This is a technology which I always feel every cath lab in the country should have, everyone who is doing primary angioplasties, because nowadays we are coming across many primary MI STEMI scenarios with a lot of calcium and non-crackable with the usual lesions. And in a STEMI with a calcific thrombus and a calcium there, I think this is the only safest technology. You can't use atherectomies that easily and without much problems. Post-CABG native CKD dialysis, elderly, and of course nowadays with the rampant use of statins, more calcium. Intense exercise is also known to increase the calcium, and warfarin patients, all these are calcium territories. You can see there, you can see the console which gives the power supply. You can charge it and keep it ready. And the connector cable is there, and this is the connector cable is plugged in, and then once you are charged there, the power is on. There are two buttons. One is the power, both lights are on. The therapy one, you can put it on whenever you want it, and then put it off whenever you don't want. The connector cable is very easy. You put a sterile sleeve onto that, like with any other device. Okay. Yeah, you can shoot that. Then you can, this catheter, IVL catheter, comes in 2.5, 3.5 and 4 mm diameters. The end is a magnetic connection only, quite simple. And once it is all a sterile sleeve, you can do the sterile sleeve. You just have to do the magnetic connection. It's very simple. And once it's connected, you know that the connection is on. The catheter is quite simple. The usual woven for wire. There is nothing new about the catheter except the preparation of the catheter is of paramount importance. this needs absolute de-airing. So you make a contrast, unlike the 50-50 or contrast what we make, our practice is to use 18 ml of contrast and 12 ml of saline, and that contrast should be used with a three-way, and then absolutely stringent de-airing has to be done, because any air bubble in the system might not only reduce the efficacy, but it can induce an IVL balloon rupture. So that is very important. And once you have done that, these balloons are all 12 mm in diameter, in length, and you can, I don't think, this I'll show you in the slide. At 12 mm length balloons, you can pass like in a routine RX system, and once it goes into the profile is about 0.43 to 0.043 to 0.047, little bit, almost slightly less than twice the usual balloon, so it might have a little bit of toughness in dealing with curves, and there are techniques to negotiate that as well. So once we connect the system, as you can show here, the 6 French guide is needed with the C2. Yeah, I think the slides should be on, please. Yeah. So this is the balloon I was talking, 12 mm between the two markers, balloon markers, but the emitters are placed eccentrically. The distal emitter is about, here you can see 4 mm gap, here it's only 2 mm gap. This is slightly important when you are trying to overlap the therapies. So at this point you should be aware. This is meant for easy negotiability. So once you connect the balloon and the balloon is placed in the appropriate lesion, making sure that you are centered around these areas, once the therapy button is on, first inflate the balloon to 4 atmospheres only. Lithotripsy delivery is done at 4 atmospheres. In a 1:1 sized selected balloon, you just have to get the balloon onto the wall or the plaque, whatever is there, and then start the pulses. The pulses are delivered. You can see the therapy on button, the second one, and the main therapy on is on in your hand, and then you direct it. Once you press it, it starts delivering 1 pulse every second for 10 seconds. So 10 pulses, and then it automatically cuts off. Once it cuts off, you have to increase the pressure in the balloon to 6 atmospheres. Wait till the therapy button goes off into green color again. Then you can deflate. This is a very important step. Don't go beyond 6. 4 is a therapy where you deliver the therapy at 4, go to 6 after the 10 pulses, wait till the button goes green, then you deflate, then the chances of IVL balloon rupture are very less. Then again, you can move the balloon distally. If you have gone down distally for the prox, and then you come back also, you can do that. The only thing is make sure when this area is there, the overlap has to be 2 mm for effective covering up of the lesion. RBP, as you see here, is 10. Most of the time, this is the difference between this and the other barotrauma-based balloon therapies like the NC balloons and the open NC balloon, ultra-high pressures, where you are absolutely relying on barotrauma. And it is the same barotromic pressure is acting on every part of the artery, including the normal vessel. Here, you don't have to go to higher pressures. It is the sonic waves which are causing the effect, and they can deal with simple pressure here. You can modify the lesion very well. Of course, there are therapies available in the peripheral arteries for transfemoral axis. People are trying in any rare scenarios of calcifications as well. This is a setup. We told about the contrast. Connection is easy. Absolutely no air should be there. You've seen the markers there. Inflate 4, activate, deliver. There are 80 pulses in the C2, and the C2 plus has 120 pulses. You can use in the main lesion, probably you can go for 2 cycles of 10 each, and then accordingly use the therapies there. In the rare case you find a bubble, which is macro bubble seen in the contrast, probably you should de-air it in situ and then again do it. Because once an air bubble is there, it makes it ineffective, and many a time the balloon will rupture. The mechanism of action, how it cracks, is by multiple mechanisms. You can see what happens is here, I'll show you. I think I have to get out of this. Okay, the electrical impulses which come from the generator, they create a sonic wave, a micro bubble, which expands in a rapid compression and decompression wave. It is almost like a 50 atmospheres pressure is generated, and it goes back again, decompression at -5. This is the only therapy which not only expands and causes pressure, but also goes in and sucks in. It is almost like squeezing as well. So fractures, microfractures are rampantly produced both in the axial direction, in the longitudinal direction, and also the change in the compliance of the entire plaque is there. So it's one of the wonderful therapies which is very safe and highly effective. There is also an effect called spallation, where the calcium, the sonic waves are reflected from one end of the calcium to the other wall, opposite wall, and then keep on helping us. So we'll go back. So just to show tremendous calcific, I'll take 1 minute more. Ruptures can be made. Highly calcific vessels, you can see that. You can use a balloon boost here. This was a balloon boost showing the all-round deep calcium, crack, plain balloons rupture multiple times. You can see the IVL balloon. It can make beautiful compliance modifications, and you can get very good results. This case, post-CABG, tremendous. Balloons don't cross. Finally, a 1.5 balloon crosses, and then you can't do any imaging as well. Multi-ruptures of the balloon, IVL does not go. This is the only scenario where you have to use a rota, tripsy, then again the results will be good. Nodular expansion we have discussed. A lot of issues with nodular lesions, but one should be aware that of the therapies available for an eccentric nodular calcium, still I personally think that this is a wonderful therapy. It is not as good as in non-nodular lesions, agreed, but among nodular calciums or calcific nodules which are non-eruptive, this is a therapy which is probably safe without any reliance on guide wire bias, and the chances of perforation are almost negligible. There are problems with the guide wire bias with rotablation, with orbital atherectomy as well, and if you see the disruptory calcified nodule data, you will be amazed that even in the calcific nodules, the results were as good as in non-calcific nodules. So the number of fractures it has produced in calcific nodules is probably slightly more than in non-calcific nodular lesions. It's a wonderful non-guide wire based, non-contact based, in situ technology which is highly specific for calcium. I had to end with this phenomenal innovation document done by Brett Esur from New York, where in a 6 mm vessel, under expanded stent, as you can see here, calcific nodule, 6 mm, the balloon IVL comes only 4 mm. You can put another NC balloon by the side, 2 mm balloon, you make it 6, and you can direct the therapy there, and they had achieved a good result. This balloon-assisted IVL, where you can increase the size of the IVL for bigger arteries, is a great innovation. Probably, even in a vessel which is only 4 with an eccentric nodule, you can use one IVL balloon of 2.5 or 3, and then another balloon. We're using the guide wire bias, putting the side branch wire into some other vessel so that the IVL balloon is directed toward the nodule, might work better. It opens up several new areas of thoughts. Shock topics can happen, they're inconsequential. Balloon ruptures IVL extremely rare if you avoid air in the balloon. Take home, one of the greatest innovations after rotablator for calcium is IVL, and it's going to stay, and everyone should have an IVL in their lab, especially in the scenario of primary PCIs in the elderly people. Thank you.